to another Diabetes Canada a webinar for healthcare providers. This is part of our diabetes and skin problems series. This is part 2 of a 3-part series. This one on how we recognize and diagnose people who might have skin conditions that are common in those living with diabetes. Once again, I'd like to introduce Lisa Max, who's a clinical nurse specialist out of Vancouver and has worked in diabetes for more than 20 years. So I'll pass it over to you, Lisa.
Thank you, Grace. I just want to take a moment to acknowledge these beautiful lands that I'm speaking to you from today, which are the Tsawwassen First Nations in BC. And I want to thank them for the stewardships of these lands and the fact that I get to enjoy them now. So we're going to talk about how we can recognize some of these skin problems. And some of them we aren't going to be able to diagnose, but some we are. So we'll walk through what are common in people with diabetes. And the issue here too is that when that patient presents to you in your clinic, in the hospital, wherever it is that you're seeing them, the skin conditions aren't really high on the priority list of our topics. When we see someone with diabetes, we're talking about their glucose control, their injection technique, how things are going from a diabetes point of view, but we may not address any skin issues. And often it's that person that comes to you and says, look what's on my arm here, what is this? So the other thing too is the comfort level of the healthcare provider. They may not have the skill, knowledge, or ability to help with the next steps. So they may feel awkward asking because they say, I don't know where I can take it from here. But there are some things that are within the certified diabetes educator scope of practice that we can recognize and treat. So we need to ask first. Then we need to look. That might be rolling up the pant leg or seeing where that skin issue is. And for some skin conditions, we can offer some potential solutions. So we have moisturizing creams. A lot of us have samples in our clinics. Better glucose control is at the top of the list of any of this. Keeping hydrated, it's one thing that we know that a lot of people struggle with, is trying to get enough fluid in over the day. Rotating their sites for injection, neuropathy screening as well. And I think that with COVID, things were very challenging to get hands-on. So hoping people are getting back in the offices at least on an annual basis to have this checked. Many of the skin conditions in diabetes are beyond our scope, but we can still help them by getting them referred to somebody else or letting them know that there is an issue there. And that's where we come to refer. So we may not have the scope to refer to a dermatologist. It might be prescriber to prescriber, but we certainly can suggest the person speak with their primary care prescriber and physician or nurse practitioner. And often, as we know, 20% of Canadians don't have a primary healthcare provider, urgent care, walk-in clinics, and maybe that hotline, the healthcare provider hotline, might be an option as well, but often they need to see the skin issue. But they certainly can help direct them when it's beyond our scope. So we're going to walk through a couple of charts of common and not so common skin conditions. We'll kind of outline the more common ones and just what it is that they would do to help for this. I put pictures on this so that you can really get a visual of it. Acanthosis nigricans is kind of an intermediate occurrence and prevalence, and we might see these hyperpigmented areas on the back of their neck, in the groin, or the axilla. And I do know many years ago, an endocrinologist in Toronto said that she had diagnosed someone standing, waiting for the subway in the summertime with diabetes because of the acanthosis nigricans. So it can be quite visual. It's quite rare to have bullous diabeticorium, which are blisters on the often on the foot, but they would do offloading at that point, and that would definitely require a specialist in that case. Diabetes dermopathy is quite common, and you can see here on the picture that it's darker spots. It can be bilateral, it can be asymmetric, and often there's not a lot of treatment for that, which is unfortunate. Diabetic foot ulcers, up to a third of people with diabetes over their lifetime might have a diabetic foot ulcers. Definitely we want to deal with blood glucose control there, getting that in as close to normal as possible, getting treatment fast. There's wound care and pressure offloading in this as well. Disseminated granuloma annulare, and you can see here that this is on someone's hand here. It's often in healthy children and young adults, but it's rashes in those rings or arcs. And the eruptive xanthomatosis is quite rare. It's little bumps on the skin, and blood glucose control is at the top of the list there, as well as lipid lowering levels. Lipohypertrophy, well within our scope of practice as a certified diabetes educator. So we're going to walk in the next module more deeply on how to counsel patients on lipohypertrophy, but we know that they can come in a concave or a convex form, so they could be dimpled in skin as well. So don't think it's just the bump on the skin. But of course, rotating the injection sites and avoiding the areas for a while can help with those lumpy bumpies in there. Necrobiosis lipoica, quite rare, so really won't walk through too much of this. There's a picture of it, and often some steroids can be partially helpful. Skin tags, I think most of us have experienced that as we get older. Blood glucose control is helpful, and removal, there's they can go to their primary provider to have that removed as well. And vitiligo, where they lose the pigment in the skin, is kind of intermediate to common for people with diabetes, which was news to me. So that's something that we definitely need to make sure that they get treatment for with an expert in the form of corticosteroid creams, laser treatments, and light therapy are possible solutions for that. So some other common skin concerns, dry skin, we mentioned before in the previous module, and that is quite common, and that's, can be anywhere on the body, and that's because of the high blood glucose causing dehydration. Infection, they're 2 to 3 times higher at a risk of being hospitalized with an infection if they have diabetes, and that treatment will depend on the cause of the infection. Nail changes. We see a lot of this where the toenails get really thick or there's fungus underneath the nails. They definitely need some oral antifungals for that, and a prescriber would need to order that. Pruritus, so this is common, and it can be itchy and often on the scalp, the trunks, or the genitalia. So there are some local creams that could go on there as well. And shingles, it actually just attended a session yesterday that over the age of 18, if people with diabetes are recommended to have the shingles vaccine. We do know it's more common in people over 50, and they are definitely at a higher risk if they have diabetes. So vaccination is important. Those lesions can be quite painful, and some of them can hang around a long time. So we don't want to expose that to the patient. So the key messages from this are that we need to ask about the skin conditions at the diabetes visit, because sometimes people don't associate it with diabetes at all. You need to look at it and see whether it's something that's within your scope. And if we can't help them with it, then we need to refer. Advise for a referral to a specialist, a dermatologist, a foot specialist, and at minimum to their primary care provider.